Okay, we're going to get started early because I believe they're going to kick us out at 12:30. It's my pleasure to be moderating this panel, and we're saving hopefully the best for last for our brave many people in the audience. This has overall been a wonderful and successful meeting. I would love to take the time to thank the council and the program committee and President Parengi for conceiving of this hopefully exciting session, and the esteemed panelists who I'll introduce in a second to take part. And it's my honor to be moderating it. I'm In-Soo Suh from NYU. I wanted to start by just talking about the Overton window. It's a term that you may know from political science. It's to describe the range of topics and policies that are deemed mainstream or acceptable to the current times. Topics that are outside of this Overton window are often regarded in the day as being radical or unthinkable. But the key here is that what's deemed radical or unthinkable in one era may change in another era as the Overton window expands, contracts, and phase shifts according to the data and the realities that are perceived during those times. The concept, fits well with medical and surgical practice as well. So lobectomy, total thyroidectomy, ablation, they're all part of our current lexicon when we think about thyroid nodular disease. But perhaps thyroid nodulectomy on one end and prophylactic lateral neck dissection on the other are largely thought of as outside that window, except for very extreme circumstances. The best of our societies push and pull at the edge of this window, and it's the main point of this session, to have thoughtful debates on some interesting and controversial topics in current endocrine surgical practice today. So the panelists and I had brainstormed quite a bit on possible topics to talk about. Of course, the list thereof is infinite, and we hope that the ones that we had settled on will tickle your brain a little bit this noontime. So yes, we are a warm and friendly fuzzy specialty, but I've taken great pleasure in designing the session to be as gladiatorial and combative for our entertainment. So some ground rules for engagement. The format is 1 hour, 3 glands, and 3 debates. We have a neat audience participation part. We're using Slido here. It's a survey poll for each debate question so we can get a sense of the breakdown of the audience. So we're going to ask that you pull out your phones every time that it pops up so we can get a sense of the breakdown in this room. We'll then start with each debate. 5 minutes for the combatant debating the pro side, 5 for the con side, and then about 7-ish minutes for open discussion with the entire panel and also with the audience. Because we need to keep track of time, I'll give each panelist a 1-minute warning and then decide on an end time for the open participation. And so audience members, we would like for you to be active participants, but please keep your questions or comments brief because we only have 6 debaters for the session. We'll then do a repeat Slido poll to see if the debate changed any of the audience's mind. We'll do the polls individually after each debate, but I'll announce the results at the end. So for those leaving for flights in the middle, including some panelists, that's tough luck. Or you can just have your friends text you later. So these are your gladiators, some of the brightest, wisest, and most incisive minds on these shores. As you can see, they all come sort of shockingly with undefeated 50-0 records. And sadly, these unblemished records will fall for 3 of them. So on Team Pro, we have Kwon Yang-do from UCSF for adrenal, Joy Shin from Cleveland Clinic, Tony Beninado, Rutgers Robert Wood Johnson. Team Con, James Lee from Columbia, Jessica Shank, University of Nebraska, and Randy Owen from Mount Sinai. In those orders, adrenal, parathyroid, and thyroid. So, on to the Slido poll and each of the questions. Please pull out your phones and vote on the first debate topic. Statement, this is going to be called Robotics Improves Minimally Invasive Adrenalectomy. I'll give you maybe about 20, 30 seconds to do so. Okay.
It's going to be an easy debate.
So I think Dr. Du is coming in with a little bit of home field advantage. But, Dr. Lee, our future president, comes in with some highly regarded credentials. So let me just write these down here. 72 agree, 27 disagree. All right, next. Medical management should be first-line therapy for normocalcemic hyperparathyroidism. Agree or disagree? Ooh, okay. All right, we have some surgeons in the audience. Okay. All right, we'll give it maybe 10 more seconds. Anyone look like they're scrambling to do their phones? No, I think you're pretty finalized. Okay, so currently 72 disagree and 28 agree. All right. Last one, unilateral lobectomy is a viable option for medullary thyroid cancer. Agree or disagree? And, okay. Probably the one with the most equipoise of the three, although there's some clear preference patterns for each question. This is good. Okay, so maybe 10 more seconds for everyone. And we have agree and disagree. Okay, fantastic. Thank you for that. We'll definitely ask for some follow-up survey. So we're going to move on directly into debate one. Robotics improves minimally invasive adrenalectomy. And to start it out, I'd like to invite past president, Dr. Kwan Yang Du, to the stage. To the stage. You have slides, I think. Yeah. All right.
Thank you. So first I cheated. I voted for James. So I can improve my number a little bit. Now, it's hard to, where are the slides? Oh, it's right there. So it's hard to debate for something that I don't do. So the only way to do this, and especially against somebody like James, is data, okay? So let me just give you a little history. Robotic adrenalectomy actually didn't get started until about 2001. And so this is one of the first original descriptions with Santiago Hogan. Now, I did my first robotic adrenalectomy in 2002. I did 3. All of them left, took 4 hours, 5 hours, 4 trocars, 5 trocars. I gave up after the 3rd case because I can do adrenal in 2 hours, not 4 hours, and so stopped doing it. And then I continued to do robot, and in fact, I was doing some robot hernia operations before people, actually for jokes, just for fun, because we had a robot and nobody else was going to be using it at the VA. And then I stopped using the robot in 2014 because the residents complained to the program director that Dr. Du was wasting their time, teaching them things that they were never used. So, speaking of Overton window. So, anyway, so that's my experience. So this is one of the big series that initially came out from Laurent Brunel that for the 100 cases, mostly from France, and show that it's a good operation, do pretty well, conversion about 5%, but cost way more. So this was not that good. But if you look at the number of robotic cases for adrenalectomy, it's been going up. This is early on. And this is here. You can see just the curve just keep going up. And I think this relates to the fact that the robot training is more and more, and a lot of people are more comfortable with robot. What about data? 46 centers. This is Eurocrine, so this is the European database. 189 robotic versus 816 laparoscopic. Lower complication rate, shorter hospital stay, no difference in conversion rate. Good. And especially useful for obese patients, larger lesions, and pheochromocytoma. This same theme is going to come up. I'm going to show you several studies. So this is the biggest one because it's from the Eurocrine study, which is all comers. So this is not specialized centers, it's all comers. Although obviously robot operations tend to be done in special centers. And this is another review from 2 French centers. Again, 97 robot, 131 laparoscopic, And they found that for tumors larger than 6 centimeters, robot has a lower postoperative complication rate. This keep coming up, okay, and have shorter length of stay. And even when they do, they did the QSUM analysis here that shows that you can have shorter operating time after about 25 cases and lower morbidity after about 45 cases. So the learning curve is not short. This is data from also from Europeans. And again, 142 robotic cases, multivariate analysis, but this is specifically just for pheochromocytoma. So again, for pheochromocytoma operations, you have lower rate of complications. Okay? So I'm telling you the same thing with multiple studies. American study, Mayo Clinic from Florida, robotic versus laparoscopic, and length of stay, 1 day versus 2 days. Operating time is actually shorter. Complication rate, again, half. So after the Mayo Clinic, we go to Cleveland Clinic. This is one of the few randomized studies. This is a study done by Aaron Berber. And operating time, conversion rate 0 versus 4 out of 27. Not statistically significant, but definitely looks significant to me. And it's very good ergonomically. It's good for your back, okay? And the same study from the same group showed that even more importantly, I think the first day of the meeting, we talked about whether or not, you should use laparoscopic, robotic, et cetera, for potential adrenocortical cancer. Positive margin rate is 19% versus 4%. So if you go to Cleveland Clinic and you have a tumor that could be an ACC, you want Aaron to do it with a robot, okay? So in summary, robotic improved minimally invasive adrenalectomy, lowered the complication rate, especially for larger tumors, for more complex operations. It has fewer capsular breach, similar cost if you have in a big center, and definitely improve ergonomic for surgeons. And I think the key issue is about learning curve, but our residents nowadays, they all learn how to do the robot. So I think this is going to take over what we do, especially for big tumors. So thank you very much.
Thank you, Dr. Du, for keeping under time. Next, we have Dr. James Lee as being the con.
Thank you, thank you, thank you. Thank you, Insoo, for the privilege of discussing the con side of the question, does robotics improve adrenalectomy? This is actually a lie. I actually have 2 disclosures. Number 1 was that Quan and I were having dim sum a couple of months ago, and we both agreed that we could probably debate both sides of this, this topic using the same exact papers, and that's what we're going to do today. The second is that this is not the difference between open and minimally invasive minimally invasive adrenalectomy, where there is a real difference. In general, when you talk about technique, I don't think there's really much of a debate because everyone's better at different things. Doesn't matter which one you choose as long as the outcomes are equivalent. Just choose the one that you're better at. So I don't actually have a big beef with a robot. In fact, let me start by, as I almost always do, by agreeing with Quan. Right, so robotic adrenalectomy is safe, and in highly selected cases, it's potentially attractive. I actually love operating with a robot. The 3D visualization can lead to better visualization. The articulating instruments can give you certain ergonomic advantages. And then, as Quan mentioned, there are some studies to suggest that there are ergonomic benefits to the robot. So all of this can lead to happier surgeons, right? But the question isn't, does the robot feel nicer to use? Insoo asked a very specific question. Does robotics improve adrenalectomy? So the central question is not whether it can be done well. Absolutely can. The real question is whether it meaningfully improves the outcomes from the operation. So from that standpoint, what matters most is does the robot make the operation safer, more effective for patients? So as Quan mentioned, excuse me, one of the largest studies to date is the Eurocrine study. He summarized the data beautifully, so I'm not going to rehash it. So the problem with this study is that this study and many others like it is that there are huge biases implicit in the study, right? So this was a retrospective review across multiple countries, across multiple institutions, the robot cases were clustered among just 7 institutions with significant expertise in the robot, right? As the authors point out, they also noted that many of the differences might be because of selection bias, right? So maybe these authors the robotic authors were picking laparoscopic adrenalectomy, the gold standard for the harder operations. So it's pretty hard to extrapolate differences here. So for example, the complication rate for laparoscopic adrenalectomy in this series, 16%. So that's awfully high. Like I think everyone in this room would say that's much higher than they see, right? So in fact, the vast majority of the current literature, including randomized data and large meta-analyses, demonstrates that robotic adrenalectomy is as safe as, but not necessarily better than laparoscopic adrenalectomy. So case in point, this is a meta-analysis by Esposito and colleagues, and it's probably the most comprehensive look at the literature on this issue. So in it, they looked at 45 studies that encompassed over 7,000 patients. And there was no statistically significant difference in operative time, blood transfusions, complication rates, readmissions, resection margins, or 30-day mortality between the groups. Now, they did find a statistically significant decrease in blood loss, conversions, time to flatus, and length of hospital stay for the robotic group. But these differences weren't really clinically significant, right? So for example, the difference in blood loss was about 18 cc's. 2 ketchup packages worth of blood loss, right? So the only significant difference that they actually found was in cost, right? So robotic adrenalectomy cost twice as much as laparoscopic adrenalectomy. So even in the randomized control trial at the Cleveland Clinic, which was beautifully done, the cost where the cost was roughly equal. The authors noted that cost parity probably only achievable in highly specialized centers that really focus on robotic adrenalectomy. So as healthcare costs rise, we're being increasingly forced to consider cost in our decisions. So the 2 techniques essentially equivalent in terms of outcome if you take all this into account. Now, as Quan mentioned, there are a couple of very specific circumstances where robotic adrenalectomy may have an edge. So for example, high BMI patients. So Aaron and colleagues found that in patients with BMIs over 35, blood loss was about 4 ketchup packages difference. The operative time was about 30 minutes faster in the robotic group. I love this finding because I don't do robotic adrenalectomy, so I can send them to Eric and Jen with a clear conscience, and I don't have to necessarily deal with this anymore. But this also underscores the main point that robotic adrenalectomy offers only marginal benefits in very highly selected patients, right? Finally, if James Cameron has taught us anything, it's that the robots are out to get us. And so, case in point, as Dr. Hashimoto mentioned to us yesterday, the Hopkins robot did the first autonomous cholecystectomy in a live pig last month, right? So pretty soon, we're all gonna be like this guy, watching the robot have all the fun. So be careful because the robots are definitely coming for your jobs. So back to Intu's question. So unless we define improvement to mean more expensive with better wrist articulation, the evidence really doesn't support the fact that it's better for the patient. Outcomes are essentially identical. And the fact that the robot adrenalectomy is twice as expensive and has the potential to put us out of business, it's pretty clear that robotics does not improve adrenalectomy. Safe alternative, but not a universal improvement. Thank you very much.
All right, so we are ready for open panel discussion along with audience comments and questions. So maybe I can start with one just food for thought. Do you think this is in part, if we look at the training models, a moot and irrelevant question? Because the idea has come up, or maybe we've seen it, that residents are getting better and better at robotics and less relatively good at laparoscopy. I mean, those in the audience, I'm sure you're great, but what do you think about that whole concept? Is this just not going to be a debate topic later?
Go ahead. Well, I think it would be debatable partially because robot is more expensive, and it is possible that it truly saves time. But in the longer term, if your young surgeons can go faster with the robot, then it will become a moot point. But for small lesions, I went to visit Martin, after many, many years, and, watch him do the operation. He can get that gland out in 15 minutes. You can't put the robot arm in there in 15 minutes. So, so whether or not it saves time, it's probably going to end up being for big cases, big tumors would be useful. I mean, I can take out 10, 12 centimeter lesions, but, when you go around the corners, it's actually really hard. So if you have the robot, I assume that would be the most helpful thing.
Yeah, and cost is always a tricky thing. Like whenever you do a cost analysis, it's like there are a host of questions. Like Carrie and Cord will tell you, like is the OR time a fixed cost versus a variable cost? So cost is a flexible thing to discuss. But I've always maintained that once you have a single site robot with all those little snake arms that you can do, your operations through single ports, that all of abdominal surgery is going to end up being done that way. And we're pretty close to that now, right? Like the new robots come out. So we may actually see a true sea change in the ability to do less invasive operations. Again, I think technique is a very personal thing. So I think the general advice is get good at something and stick with it.
In rough order, Gita?
Hi, great debate. Geeta Lal, Iowa. So full disclosure, I don't do robotic adrenalectomy. So I'm going to come at it, though, from the ergonomics lens that you presented as part of the discussion. And, maybe 20 years ago, we weren't always thinking of sort of outcomes and trials and things from the perspective of patients, right? Patient-related outcomes. I would argue that more and more, as residents become proficient with robotics, we're going to start to have to factor surgeon perspective outcomes relating to ergonomics. In your cost discussion, there's no mention right now of the loss of a surgeon, their income, how that affects access to surgeons, et cetera. So I'm just putting a little bit of a different twist on the cost discussion.
I think that's a great point. But one of the things that we're learning from our colleagues in surgical oncology at the Pancreas World is that every operation comes with ergonomic costs. And so, if you're doing a 5-hour Whipple, you're going to get neck issues. And maybe the robot mitigates that a little bit. But yeah, I think it's a great point that maybe it's ergonomically a little bit better, but it doesn't erase. I don't think the robot erases the ergonomic cost.
No, but certain things, depending on what the surgeon's pre-existing sort of pain points are, definitely get better with the robot. And as the technology evolves, that'll continue to kind of, I think, affect decisions. Just a different perspective.
Great.
Great. So I think that one of the things is the volume outcome. I think for a high volume adrenal surgeon, there probably isn't a huge difference between the two. But the reality is that most of the people doing this are not high volume. Even in this audience, there are very few people who are doing a huge volume. As we look at our new trainees coming out who are much more comfortable on the robot than they are with a straight stick, do you see does this data actually apply to our younger faculty or our people who are lower volume surgeons in the community? Is this robot give us an opportunity to allow safer care for those?
Well, I'll answer that. I think the answer is yes. Our residents now are trained to go out there doing inguinal hernias with the robot, which I think is the craziest thing in the world. But if you're going to do ventral hernia with the robot, that's actually very helpful. I think adrenalectomy is somewhere in between. It's not completely useless, and there is a reasonable delta at especially the more difficult access cases.
Yeah, so I think it's a great point. And, this is what we saw in the early days when we converted from open operations primarily to laparoscopic operations. I think we're at the same inflection point. I think that what we are going to see is that trainees in the future are much more facile robotically. I think that's probably what we're going to see. I don't think we're there yet, and certainly the data doesn't support that currently.
I'd like to point out that Dr. Du in the pro position said that robotics is not completely useless, which I don't think
Yes.
is the most strong statement, but
I'm going to let
Karen.
Barb go first because I know I want the last word.
Okay. So
Do any of these studies talk about bedside first assist? Because I think that's critical for a lot of these cases. And in some places, you don't have enough first assist, or you get a varying level of resident who may have never seen the case, or you have, when we were at Ohio State, we have a huge number of bedside first assist just for the robot, which makes a huge difference. Now I'm in Tucson, we don't have that, I'm back to square one. There are definitely cases where I want to be at the bedside, where somebody who's a first assist is just not going to be able to do what I want them to do. So there's, I think, a huge amount of variation, and it's also case dependent.
Yeah, I think that's an important point, and it's very similar to when you go from open to laparoscopic. You know, what does the assistant do? What does the surgeon do? In general, people tell you that the robot you set up the assistant part of it much better, but then you need a bedside assistant, which is a different story. But the setting up of the field, in general, my read of the literature and my own experience with it is that robot is, doesn't mess up like your residents would.
So it's a good question about the data. I don't think I've read anything that talks about it directly, but I think they get at it obliquely through the idea that cost parity, time improvement really comes from robotic specialty institutions that may have teams that are like what you're saying. And actually, we experienced this in another field at Columbia where we hired a world-class robotic cardiac surgeon at his home institution. He had everything that you could possibly want, dedicated first assistants, et cetera. When he came to Columbia and he had to build that team, his operative times almost doubled. And so I think that's an incredibly important point, and part of the reason that it's not quite so easy to populate the world with robots.
I just want to make another comment relating to learning curve. Frequently people talk about learning curve and this and that. To learn how to do a robotic operation, you actually have several learning curves. You need to know how to do adrenalectomy, number one, which takes some learning. You need to know how to do it laparoscopically, which takes some learning, with the endoscope and all that. And then you need to know how to use a robot. And all those things, they overlap, but they don't necessarily together. And what I can say is that nowadays, the learning curve for using the robot is basically gone because they know how to use a robot. But they still have to learn the other things.
And so, thank you. In the interest of time, we will move on, but that was an excellent discussion. Thank you for everyone's comments. I don't think, Carrie, you had a last word that you wanted to give?
Follow up on what Geeta said, because in my case of one, and I do a high volume of robotic surgery, I first of all, the neck pain is 100% down. I don't care what study it talks about. It's also nice that you can take a step back. You can pull your head out, like, Theo, take your head out. The instruments do not move. You can even go to the bathroom, stretch, do your little moment where you do your ergonomic stretches. It is 100% better for teaching as well. So, and you can do the whole operation by yourself because you can put instruments in place.
Yeah.
Anyway, those are my thoughts.
But you can also stop laparoscopically, correct? You can also take a break laparoscopically, correct?
Ooh, uh-oh, sorry, hold on. We did
You
open
leave
this.
your instruments in place.
Okay, so I clearly did not prepare this well. We were going to do a Slido poll right now, but we're not. So we'll save that till the end, okay? All right, we'll move on to debate number 2. Medical management should be first-line therapy. So just remember your strong opinions for each debate, and then we will do the poll at the very end in combination. So the topic for parathyroid medical management should be first-line therapy for normal calcemic hyperpara. Pro is Dr. Joyce Shen, and I'm sorry.
Thank you. I have no disclosures, but I will fully disclose that I was assigned this topic, not chosen. Okay, I just want to start with the definition of normal calcemic hyperparathyroidism. So we define it as elevated PTH in the setting of consistently normal serum and ionized calcium levels. The 4th International Workshop on the Management of Asymptomatic Primary Hyperparathyroidism states that PTH should be elevated on at least 2 occasions during a 3 to 6 month period. And the reason I bring this up is that when we were first becoming familiar with this phenomenon, it was a diagnostic challenge for all the secondary reasons, as you know, and listed here. When we were first becoming familiar with normocalcemic hyperparathyroidism, we were not always consistent with the diagnostic criteria, especially with checking ionized calcium on all of our patients, which has really complicated literature reviews. And I just want to be aware, I want you to all be aware that many of the studies that have been done, which is not a lot, unfortunately, is that there is much selection bias because these studies are selecting for patients who are truly symptomatic, because it is very rare that you will do a full parathyroid disease workup on a patient who is asymptomatic with always having normal calcium levels. So how to explain normocalcemic hyperparathyroidism? Well, some consider it an early or a milder form of a classic primary hyperparathyroidism. Some say that patients are just live in a narrow range of calcium where a calcium level of 10 may be considered hypocalcemic for them. There's a lot of different reasons, as you could see here. However, none have been proven. Unfortunately, there's also no good data regarding optimal treatment strategies due to lack of evidence-based data. The fourth international workshop, once again, can only give expert recommendations on when to consider surgery, and it's very vague. They say consider surgery if there are complications of the disease, but monitor if there is no complications at the time of presentation. So not a lot of data supporting that. What we do know is that there is lower imaging and surgical successes due to a higher prevalence of multi-gland disease and normocalcemic hyperparathyroidism. This large study done at our institution involving 2,000 patients looked at the correlation between preoperative calcium and preoperative PTH levels and disease status and gland volume. And what we've seen is that there was really good no correlation between the preoperative values and the disease status and gland volume, unless the calcium and the PTH levels were quite high. But what was the most interesting about this study, and supports my case, is that the surgical removes single adenomas, double adenomas, and hyperplasia all had similar aggregate gland volumes. So which could allude to the fact that, with these smaller gland volumes, the imaging localization rate is lower in these patients with multi-gland disease. And the surgical success, as we all know, is quite challenging in these patients to try to find multiple glands of smaller volume. Unlike the debate before, there's very limited data on the outcome benefits after surgery for bone mass, nephrolithiasis, and quality of life, because to be honest, if you really truly look at the studies, only a few completely and fulfill the diagnostic criteria of normocalcemic primary hyperparathyroidism. So what do I advocate for medical management? Well, there are studies that show that bisphosphonates do have significant improvement at several different bone density levels in the cohort of patients treated with alendronate and vitamin D versus just vitamin D alone. And as we all know, we do use cinacalcet or Sensipar to drastically decrease serum calcium levels. And there is currently a prospective randomized study of 10 patients, and yes, I do know that is a very low power, but it has shown reduction in the number of diameter of kidney stones in both hypercalcemic and normocalcemic patients. Oops, sorry. So that is the conclusion of my debate, and I would just like to say, unless there is compelling evidence, and there's definitely more compelling data really needs to be determined before we offer surgery on all of our normocalcemic hyperpara patients.
Thank you for your bravery. So on the con side, we'll be inviting Dr. Jessica Shank. You have slide, yes. There we go.
All right, hello everyone. I would like to send a kudos out to the audience for those that remain till the very end of this amazing AAES meeting. I have no disclosures, and I'm going to be running through some of the beginning of my presentation fairly quickly just because Joyce covered some of it, albeit with the limitations of my intrauterine parasite causing some increased blood volume and some shortness of breath, so bear with me. So reviewing some of the definition that Joyce already covered, obviously there is a lack of consistency in the diagnostic criteria that was first noted within the early 2000s. I think we can all agree that some of the diagnostic criteria should include normal calcemia, both albumin-adjusted serum calcium levels that are normal, as well as normal ionized calcium levels, with an elevated PTH on separate occasions separated by a time period of 3 months or more. Importantly, we need to make sure that we are excluding other secondary causes of hyperparathyroidism when giving a patient this diagnosis. This is an incredibly rare entity, so we know anywhere from 10 to 20% of our primary hyperparathyroidism patients will have normal calcemia, and within the general population, there are a couple of large series that estimated between 0.5 and 0.2% respectively out of Sweden and UK, in which they were screening females either for mammogram or bone mineral density that were found to have normal calcemic primary hyperparathyroidism. So as Joyce mentioned, the difference in presentation between hypercalcemic and normal calcemic primary hyperparathyroidism is that typically our hypercalcemic counterparts present asymptomatically, and this is just discovered on routine laboratory evaluation. Whereas with our normal calcemic patients, there's certainly a selection bias. We know these patients present with either symptoms or end organ damage that then prompts a PTH evaluation in the setting of normal calcemia. And we know that around 20% of these normal calcemic patients will subsequently develop hypercalcemia if this were to go untreated. There's a variety of recommendations from various workshops and societies, essentially stating either no consensus on recommendations or considering surgical management in those patients that happen to be symptomatic and or potentially with an imaging localized disease. So for our preoperative and our intraoperative disease management, again, as Joyce mentioned, this is more likely to be a multiglandular disease process with smaller volume glands. Therefore, our sensitivity in identifying a localized disease process is decreased compared to the hypercalcemic counterparts. For example, 4D CT localization rates, sensitivity being around 50 to 55% for normal calcemia, and 75 to higher rates in our hypercalcemic group. Of note, there's a lot of different literature that evaluates PTH decline in these patients with different outcomes, but needless to say, summarizing some of that information, the initial PTH value may start at a lower level and the decline may take longer in the normal calcemic counterparts. So this will require some patience on the part of the surgeon. We know that there's a higher rate of conversion to four-gland exploration in our normal calcemic patients, around 13% compared to 4% in those that are hypercalcemic. So our surgery goals for our classic hypercalcemia group is that we want to normalize our calcium levels long term. But for our normal calcemic patients, they're already eucalcemic, so our goal has to do with PTH levels. And again, we know that there's a higher rate of persistence of disease if we're just evaluating PTH long term. Even upwards of 50% of these patients will be found to have persistent disease. Despite that, however, lack of biochemical cure is not an indication of symptomatic or end organ improvement, which I will be covering shortly. So starting out to evaluate bone mineral density, I'm just going to highlight one of the studies out of MD Anderson, which was a retrospective review over a 10-year period for patients that underwent parathyroidectomy for both hypercalcemic and normal calcemic hyperparathyroidism. Out of the 661 patients that were operated on, 68 of those were found to have normal calcemia. And again, they frequently had multiglandular disease at 31% compared to 18%. 28 out of the 68 patients who had normal calcemia and underwent surgery had bone mineral density evaluations both preoperatively and postoperatively with follow-up at 6 and 18 months. A quarter of those normal calcemic patients were found to have elevated PTH levels at 6 months. However, that being said, bone mineral density was shown to improve in this normal calcemic group at a significant level at both the lumbar spine and at the total hip. So moving on to more closely evaluate urinary symptoms or kidney stones, I'm going to highlight a review out of Italy, around 900 patients that underwent surgery for hyperparathyroidism. Again, that number was reduced once we excluded secondary causes of parathyroid disease. And out of the 731 patients that remained, 154 of those were normal calcemic. And I'll review and compare the results between the groups with hypercalcemia to normal calcemia.
Just 1 minute warning.
Oh, no. Okay, I'll hurry. So 42% of those patients with normal calcemia were found to be symptomatic compared to 26% of the hypercalcemic patients. 16% of normal calcemia had kidney stones compared to 23% of the hypercalcemic group, and 25% had decreased bone mineral density compared to 19% of the hypercalcemic group. The histologic findings varied. As I mentioned, higher rates of multiglandular disease in the normal calcemic group at 13%, with similar breakdowns between double adenoma and hyperplasia. So out of the 65 patients that were found to have symptomatic disease in the normal calcemic group, this is broken down by end organ damage. So looking at bone mineral density first, 39 had decreased bone mineral density preoperatively. 12 of those patients had DEXA scan postoperatively that showed no progression of disease in 91% of patients, with improvement in 41% of those patients. 10 patients who had, out of the 25 who had urinary symptoms or kidney stones, had an ultrasound done after surgery, in which case 40% of patients had no evidence of disease on follow-up ultrasound, with stability in 50%. 37 patients noted subjective improvement in their clinical status after surgery. Similarly, when evaluating quality of life,
I hate to interrupt, but I think we're going to have to
all right.
wrap it up.
Sorry to go over time.
Thank you. Sorry, we do want to leave some time for discussion here. Folks who would like to debate the normal calcemic topic, please come up to the podium. I will ask one. Regardless of whether you agree with the debate topic or not, if you were to medically manage them, what would you optimize as being the best standardized protocol? Is it nothing? Or, there's variability in people's ideas of normal vitamin D levels. Would you jack that up with calcitriol, acetylcalcid?
Yeah, so
Resorptive agents.
Yeah, there's not much in medical management as stated. It's observation, routinely checking calcium, PTH, vitamin D levels, and if they're symptomatic, then treating it, bone density with alendronate, or decreasing calcium levels with cinacalcet. And also obviously repeating bone density scan every 1 to 2 years and just observing short symptoms.
Can I ask
All
a
right.
question?
Of course.
I think the biggest problem in normal calcemic hyperparathyroidism is the diagnosis itself. Every clinic I get some people with normal calcemic hyperpara, and they either have regular hyperparathyroidism, they just didn't do the proper workup, or they actually did not. They have vitamin D deficiency and all that. It's less than 1 out of 10 have actual normal calcemic hyperparathyroidism. So I think that's the biggest problem, is not whether or not we treat it medically or surgically.
Doug Fraker,
Doug.
Philly. I have to agree with my senior resident, Dr. Du, as always. First thing is ionized calcium. At least in the Philadelphia area, LabCorp Quest do an awful job of ionized. You can have calciums of 11.0 and an ionized of 5.1. For most people where you're checking ionized, the ionized tends to ride higher than the total in the older age population. Then you have to put it on ice, pH correct. I do not look at any ionized. And so one question when you're doing this, are you doing ionized, which is really the pertinent calcium level, and you're doing it correctly. But there are, and the other thing, vitamin D. We're all vitamin D deficient. I say we either need to change the scale or get more sun. But put them on vitamin D, put them on calcium, recheck labs in like 3 months. But this is a real phenomenon with real pathology, and it's always mind-boggling that you have a 500 milligram dark brown gland in a patient that has an ionized of 1.26 and a total of 9.5, but you see it every now and then. They have the actual clinical history. So I guess my only comment is, for all the people doing this, make sure you check the vitamin E, make sure you check the ionized, and then the people really need it. It doesn't make sense to me that the cynic calcium would work with you. Calcium is truly already normal, right? And in terms of intraoperative PTH, people say, oh, in the normal hormonal, that drops slower. That's not true, because the normal hormone, you still have high calcium, so your normal glands are suppressed by the high calcium. In the normal calcemic, the question is, if you truly have like a mid-range calcium, for whatever reason your physiology is, how are your normal glands suppressed? Because they're not in a high calcium environment. Thank you for the presentation.
Thank you. Michael?
Hey, Michael Yeh from UCLA. So such a complicated question that we're all dealing with now. So I want to tell the audience that we tried operating on a bunch of people with this biochemical profile. The results were mixed. And about half of them got better with respect to bone mineral density changes, and many of them did not. And if I see a patient, particularly if the calcium is in the 9s, I try hard not to operate on that patient. I'll just give you one salient example of a prominent socialite in LA, and we operated on her. She had calcium in the 9s, PTH in the upper double digits. We did an aggressive subtotal parathyroidectomy, and the finding very often is subtle hyperplasia, most often. 3.5 gland resection, good remnant, good PTH drop into the high teens. 6 months later, her PTH was right back up to where she was. And that's a very common result, and I don't think we can say we have helped that person. We didn't change the biochemical profile, ultimately, and her bone mineral density did not change. So today, I try very hard not to operate on people with calcium in the 9s, assuming we have the correct diagnosis, right? Assuming all the biochemical workup has been correct. Then there are people with calcium 10.1, 10.2, 10.3, and a PTH in the triple digits. They often have the classic form of the disease. And if you give them enough time, that calcium will fluctuate, and they will have a few days where the calcium is above normal. And I think that group is, what I'm saying is a heterogeneous group. And I think if your calcium is in the 10s and your PTH is in the triple digits, many of those people will have the classic form of the disease and benefit from surgery, whereas this other group, this other phenotype with the calcium in the 9s, sometimes I think that's just a normal physiologic, normal variant.
Great, thank you. Abby?
Abby Figueroa, University of Nebraska. No disclosures, but one disclaimer. Dr. Shank and I lament these patients in her office or mine on a daily and or weekly basis. My question was astutely covered by our previous 2 question askers, but I find in my practice that these patients tend to be very total body calcium depleted for whatever reason. They are avoiding calcium agents, and so my strategy is often to convert them from a normal calcemic to a hypercalcemic classical primary hyperparathyroidism patient by calcium challenging them, not giving supraphysiologic doses, but giving RDA amounts of calcium, and oftentimes they come back in 3 months and now they have that calcium of 10.2. So I'm curious if any of the other panelists establish that in their practice. Thank you for this very amazing session.
That's a great question.
Thank you for that excellent question, Dr. Fingerat. Due to the mentorship of me joining the practice with Dr. Fingerat, I have since adopted a similar calcium challenge for some of these patients, and it does end up clarifying the disease process and helping with the decision making.
So I don't routinely calcium challenge, but we just really make sure that we get the definitive diagnosis. I believe that, as I started my presentation, that is really the challenge of this phenomenon of what we consider normal calcemic hyperparathyroidism. So I think it is a diagnostic challenge still to this day, so we got to be really diligent in checking off all the boxes to rule out any secondary causes.
Great. Last comment, Barb?
Yeah, I'll say I drag my feet on this as much as possible. And it drives me nuts, so I try to find every possible reason for secondary hyperpara. And Lynn Yip tried to send me somebody who was out in Tucson for a month and he called me, he said, I want my operation in a month. They worked him up for 2 years or so. I said, you are not on my timeline, so I think Lynn's gonna operate on him. But my question is around the data in the papers, and I think the diagnosis is extremely important in terms of including that ionized calcium level. And I would say that most of the surgical studies that I see and things that get presented here, we are always up at the microphone going, saying, where is the ionized calcium, right? And so I noticed in the second presentation that you had a couple studies and it talked about total serum calcium. Did they not talk about ionized calcium? The other studies that got presented today, do these include ionized calcium where you say, yeah, it truly is meeting the definition of normocalcemic primary hyperparathyroidism? And so I think, because I just toss those out and I say most of those patients are going to be secondary because you have not proven it, so it's bad data.
Thank you. It's an excellent point, and why a lot of the literature out there is limited, particularly because we didn't come up with the diagnostic criteria, if we can call it criteria, until the early 2000s. And a lot of the literature that has larger volume includes patients from late 90s, early 2000s, prior to the adoption of routinely checking ionized calcium in this patient population. So you pointed out an excellent point on the limitations on a lot of the studies that I highlighted.
In the interest of time, we'd like to give Dr. Bendinato and Dr. Owen a fair share, which is very short. So the last debate topic, unilateral lobectomy is a viable option for medullary thyroid cancer. Tony Bendinato.
Thank you, Dr. Suh, for the pleasure of the podium. I will be relatively brief, and I hope in my few slides to convince you that unilateral lobectomy is a viable option for medullary thyroid cancer. I'm going to start with that word viable, which means having a reasonable chance of succeeding. So I don't really need to convince you that this is a perfect operation, but maybe a reasonable operation for some patients. So the quote-unquote standard treatment for medullary thyroid cancer is total thyroidectomy with bilateral central neck dissection. And this is recommended for the entire bucket of patients with medullary thyroid cancer, both those with hereditary disease and the sporadic form of disease. However, we know that the sporadic form of the disease is often limited to one side of the thyroid with a very low rate of multifocal disease on the other side. So, can we safely perform a unilateral thyroid lobectomy and central neck dissection on a subset of patients with sporadic medullary thyroid cancer? So, the ATA says no. This is the 2015 ATA guidelines, which have not been revised again in about 10 years, which currently recommend total thyroidectomy with central neck dissection for all patients with medullary thyroid cancer. So I'll start with this. This is a proof of concept study out of UCLA, looking at patients that underwent treatment of medullary thyroid cancer. You could see the tree on the right are those with sporadic disease, and of those with sporadic disease, only 4 patients had occult contralateral disease, representing 5% of the population. So we could see that, again, that it's reasonable in theory to consider that we could remove half of the thyroid and that there may not be disease on the other side. This is in theory. Is anyone actually doing this? I don't see Professor Maiucci here anymore, but I know he was here. He is probably, if he were here, he'd be shaking his head at us like, what is taking us so long to do this? Because he's been doing this since 1996. So this was published in 2002. Since 1996, the group at the Kuma Clinic has been performing lobectomy with isthmusectomy and central neck dissection, as well as prophylactic lateral neck dissection for patients with sporadic medullary thyroid cancer. Biochemical cure was achieved in 80% of patients, but of note, sites of recurrence were not in the contralateral lobe, but however, bone, liver, lung, brain, etc. Importantly, extent of surgery was not associated with long-term outcomes, and they followed up this study in 2008 with similar outcomes. This is a more recent paper out of China showing they eventually propensity matched patients who underwent total thyroidectomy versus hemithyroidectomy, again with comparable rates of biochemical cure, similar recurrence-free and overall survival, and again found that extent of surgery was not associated with risk of recurrence-free or overall survival on multivariate analysis, controlling for patient and tumor factors. This is a timely meta-analysis that just came out about 2 months ago, looking at 9 studies, including over 1,000 patients. Most patients underwent total thyroidectomy, but about 38% of patients underwent lobectomy. Central neck dissection was performed about 90%. Of note, about 75% of these tumors were smaller than 2 centimeters, so this group sort of focused on that population. And they saw no differences in mortality, overall survival, recurrence at 5 years, biochemical cure rate, or distant metastases. Some of these papers were very heterogeneous, so some of this data should be taken with a grain of salt, and I'll pass through these because I know we're short on time. So what do we do with this data? Is anyone telling us that we are allowed to do lobectomy for medullary thyroid cancer? The Japan Association of Endocrine Surgery specifically recommends unilateral lobectomy with central neck dissection for patients with sporadic medullary thyroid cancer. But what about our American patients? The NCCN guidelines recommend consideration of the same. Lobectomy can be considered in select cases without germline RET mutation if no concerns for abnormal adenopathy and contralateral nodules. So is this a viable option? According to 2 sets of guidelines, yes. We can be confident in those with small tumors clinically confined to the thyroid, especially those with post-op normalization of calcitonin. I think question remains on our comfort level with whether or not contralateral operation would actually help improve outcomes for those with larger tumors, clinically evident lymph node involvement, or incomplete biochemical results. Again, is the remnant calcitonin coming from the other lobe, or is it coming from elsewhere in the body? So I think this is reasonable, viable. Thank you.
Bring it home, Dr. Owen.
Thank you to the AAES for inviting me to participate in this panel discussing medullary thyroid cancer and whether total versus hemithyroidectomy is the most appropriate treatment. Frankly, I wasn't enamored with the assignment of taking the old school total thyroidectomy side of things, but as I did the research for this panel, my thinking shifted in that direction. But before we get to the question of hemi versus total, the real question is, why was I chosen to be the last speaker of the last panel of the AAES? And one possibility is I'm the most interesting and relevant speaker to try to keep people interested and not change their flight and run out of here. The other possibility is I'm the least interesting and relevant speaker, so left to the very bitter end because most people will have already departed. Or Quan paid off Ensu. Let's get down to business. Start with the guidelines. Truth is, the NCCN revised their guidelines just last year and recommended total thyroidectomy except in select cases. The ATA and other societies also recommend total thyroidectomy. As you know, guidelines don't just come from a few yokels having some drinks and checking open evidence for the latest word. These are the top people in our fields, poring over the relevant data over many months, debating the pros and cons of each point, considering the good of not just the patient in front of them, but the patients of hundreds of practitioners around the globe, and producing consensus guidelines that we can rely on. There are many papers arguing for hemithyroidectomy for medullary thyroid cancer, but let's go right to the elephant in the room. Since the 2025 NCCN guidelines came out, the JAMA meta-analysis article by Julianne Sosa and other distinguished authors was published and is a compelling study analyzing 9 high-quality publications concluding that oncologic outcomes are similar between total and hemi. Rates of survival and biochemical cure showed no difference between the two choices. However, it should be noted that this was not an equivalent study. And very importantly, though no difference was noted in structural recurrence at 5 years, beyond 5 years, hemithyroidectomy was over 7 times more likely to have structural recurrence. Of the 9 studies included, risk of bias was calculated to be high in 4, moderate in 4, and low in only 1. And all included studies were retrospective, making them susceptible to selection bias, incomplete data capture, and unmeasured confounding. Well, what are the arguments for total thyroidectomy then? The first is demonstrated in this study by Denise Lee, Michael Ye, Dr. Mao, and team, which showed that fully 5% of total thyroidectomy specimens were found to have occult contralateral disease not detected on preoperative ultrasound. So are we willing to leave disease behind in 1 out of 20 patients? Perhaps lobectomy should be considered for less experienced surgeons with a higher rate of nerve or parathyroid injury, or when nerve monitoring signal is lost after the lobe with gross disease has been removed. But for well-experienced surgeons, it would seem reasonable to remove the whole gland to avoid leaving disease behind. If we leave in the contralateral lobe, we leave behind the baseline production of calcitonin by the remaining normal C cells. Since calcitonin is the most reliable and specific marker for surveillance, it follows that total thyroidectomy simplifies postoperative surveillance. My last point is that we have all lived through the appropriate data-driven de-escalation of the treatment of differentiated thyroid cancer. But it is very clear that medullary is not the same as papillary, follicular, or oncocytic thyroid cancers. Overall 10-year survival rates are very different between these two diseases, and although our data suggest excellent 10-year survival rates for properly treated MTC of low stage, we want our patients to live longer than 10 years after treatment. And the overall pattern of disease, including evidence that late structural recurrence is more common after lobectomy, suggests that we should be careful to de-escalate without very solid evidence. Thus, I'm here to argue that total thyroidectomy remains the standard for medullary thyroid carcinoma due to carefully developed guidelines, definitive treatment of bilateral disease, cleaner calcitonin surveillance, increased rates of long-term structural recurrence with lobectomy, and because the evidence for lobectomy is insufficient. Here are my references, and thank you to Megal Shah, my fellow, for help with everything.
All right, in the interest of time, we'll have 1 comment.
I know we have to be out of here in a few minutes. I stayed here because you're all here, but also to support Randy, who was my partner in New York for over a decade. So congratulations on a great panel. A couple of things both presenters left out is the genetics of medullary thyroid carcinoma, and I think that really should be highlighted when you're risk stratifying. So genetic testing, is there mutation, and how does that affect your management, because that might clarify low versus total. And secondly, the doubling time of calcitonin, I think, is different than the doubling time of thyroid globulin. If you do a lobectomy and you're monitoring thyroid globulin levels, are very difficult to follow, they're harder to interpret, but I would argue that the calcitonin probably is a little bit more accurate. So what does the data show on the accuracy of following doubling times when you leave tissue behind? And thirdly, leaving the isthmus behind when you do a lobectomy, are you doing isthmusectomy right at the junction of the contralateral, of the ipsilateral lobe, if the purpose is to save thyroid function, knowing that C cells are not present in the isthmus, they're only in the lobes? Is that part of the strategy if you're doing a lobectomy, to really drill down to the technique of how you should do a lobectomy if the purpose is to save thyroid function?
So to the first point, Respectfully, I did discuss genetics at the beginning of my talk. So no, this is not appropriate for those with hereditary medullary thyroid cancer. This is specifically for those with sporadic disease. So I agree, the question remains, like, do you delay surgery to wait definitively for that RET mutation to come back before you decide what operation to offer people, or is it just enough to like check metanephrines and a PTH and just go for it? And I think that's something we need to debate. Professor Maiucci's papers do look at calcitonin doubling time in patients with the contralateral lobe left in, and have shown this to be reasonable to follow this long-term in that setting. Personally, I would probably take the Isthmus just because I always do when I do a lobectomy, but I totally see your point about C-cells.
So with that, I would like to ask you to share in a round of applause for this incredible panel, incredible discussion. In the remaining 1.5 minutes, please pull out your phones for the last degree of polls. So robotics improves minimally invasive adrenalectomy. I'm gonna move on, I think. Maybe we'll have the results by the end. There we go. So it was 72 to 27, and it has changed to 67 to 33. So we've gotten 2 people to cross over. All right, fabulous. Next, medical management should be first-line therapy for normal calcemic hyperpara. If I had the Jeopardy music, I would do it now. Okay, and stop. It was 28 to 72 agree. It is now 53 to 47 agree. Congratulations. Lastly, unilateral lobectomy is a viable option for medullary thyroid cancer. Agree or disagree? Just to warn you, it was 63 to 37 in favor of agree. And let's see what the results are. I think everyone has done it. 82 to 19, it's 81 to 19. Congratulations to the winners. And that concludes our session. Thank you very much.
Good work. Thank you, Insoo, and all the panelists for a great session. Randall, I am the most boring, so I get to go last. I'll be very brief because I know everybody's got to get on to the next thing, but I just want to express gratitude to a lot of people in the room. First, to Courtney and Barry for the local arrangements. Everything was wonderful, and we all enjoyed ourselves. It ran perfectly. To AMR, especially Lauren, Gina, Hillary, and Zoe for their expertise and all of the heavy lifting. To Abby and Amanda and the whole committee for designing an outstanding program, and for all of the speakers for executing on it so well. To Saray, Carrie, Jim, and Rachel, and the council for outstanding leadership this year. And to all of the donors who helped the foundation reach $35,000 last night in funds raised. And most importantly, I want to thank all of the attendees for making this meeting what it is, for coming and participating. You are the lifeblood of this association. And everyone, please put May 22 through 24 next year on your calendar. Next year's meeting in Sacramento is going to be legendary. And with that, the meeting is closed. Safe travels.